Hello, this is Dr. Philip May, and I'll be speaking to you today about improving bone health with physical activity. And I'll also be covering some of the physiology that relates to how physical activity can improve bone health. So let's get started. Now, according to the National Osteoporosis Foundation, there are two types of exercise which can improve bone health. There's weight-bearing exercise and there's muscle strengthening exercise. Now, weight-bearing exercise can be divided into high impact and low impact. Examples of high impact weight-bearing physical exercise include dancing, doing high impact aerobics, hiking, jogging, running, jumping rope, stair climbing, and tennis. Low impact weight-bearing exercise examples include using the elliptical training machines, doing low impact aerobics, using stair-step machines, fast walking on a treadmill, or outside. Now, muscle strengthening exercise can also improve bone health. Examples include lifting weights, using elastic exercise bands, using weight machines, lifting your own body weight, functional movements such as standing and rising up on your toes. Yoga and Pilates can also improve strength, balance, and flexibility. However, certain positions may not be safe for people with osteoporosis or those at increased risk for fracture. For example, exercises that have you bend forward may increase the chance of breaking a bone in the spine. A physical therapist should be able to help you learn which exercises are safe and appropriate for you. Now, there are also non-impact exercise. While they don't directly improve bone health, they can be useful in reducing the risk for fracture. Non-impact exercises can help you to improve balance, posture, and how well you move in everyday activities. And these exercises can also help to increase muscle strength and decrease the risk for falls and broken bones. And some of these exercises include balance exercises that strengthen your legs and test your balance, such as Tai Chi, which can decrease your risk for falls. Posture exercises that improve your posture and reduce rounded or sloping shoulders can help you decrease the chance of breaking a bone, especially in the spine. Functional exercises that improve how well you move can help you with everyday activities and decrease your chance of falling and breaking a bone. For example, if you have trouble getting up from a chair or climbing stairs, you should do these activities as exercises. A physical therapist can teach you balance, posture, and functional exercises. For more information, get in touch with the National Osteoporosis Foundation in Washington, D.C., or you can call them at 1-800-231-4222. Okay. Let's get into some anatomy and physiology, and let's start with the bone cells. There are three types of bone cells: the osteoclast, the osteoblast, and the osteocyte. Now, osteoclasts cause resorption of bone and a release of calcium into the bloodstream. And this action prevents hypocalcemia, and it also helps to remove old bone and replace it with new bone, along with the osteoblast. Osteoblasts produce osteoid, which is the non-mineral bone matrix, kind of like jello, but can also stimulate osteoclast production via RANKL, and we'll be talking about RANKL later on. Now, this can happen if OPG doesn't prevent it. OPG is osteoprotegerin. We'll also be talking about that. Osteoprotegerin is a RANK ligand inhibitor, and the drug Prolia acts like OPG. Now, osteocytes, which are embedded in bone, come from osteoblasts, produce sclerostin and rank ligand, and as well as the osteoblast. Now, the osteoblast does not produce the sclerostin, it is thought, but the osteocyte does come from the osteoblast. It's a more differentiated osteoblast, which is embedded in bone. So it is possible that the osteoblast does retain some of that potential. Now, CTX, which stands for C-terminal telopeptide of type 1 collagen, is a measure of osteoclast activity, and it's a breakdown product of collagen, of type 1 collagen. And when the osteoclast is very active, you can see the CTX blood levels go up. P1NP stands for procollagen type 1 N propeptide, and this is produced by the osteoblast. So as you can see that the osteoclast and the osteoblast have their own unique products, and the clinician can use this information to tell the level of activity of these cells. And bone turnover, remodeling, and coupling refers to the activity of the osteoclast and the osteoblast. And these cells are normally balanced. Normally the osteoblast and the osteoclast kind of work together so that neither one of them is doing too much building or too much destruction. Now here's a graphic representation of bone turnover, also representing that this process of bone turnover is responsible for calcium homeostasis or bone remodeling, and those are two different functions. Maintaining a normal serum level of calcium is one thing, and bone remodeling is another. So it's very important to keep a normal calcium level, and this process of bone turnover ensures that. And it's also important to remove old bone and replace it with new bone. And the bone remodeling function is responsible for that. So, but either way, just looking at the slide on the far left, you can see what happens if there's vitamin D deficiency. That's vitamin D deficiency can result in impaired intestinal absorption of calcium, and this can lead to hypocalcemia. And if the vitamin D deficiency is not corrected and the hypocalcemia persists, then this will lead to, through a series of steps, it will eventually lead to the activation of osteoclasts. You can see at the bottom there. And the osteoclast then begins to remove calcium from bone. And eventually the repair kicks in, performed by the osteoblast on the top there. The osteoblast starts making osteoid and fills in the pits made by the osteoclast. And in this particular slide, the big arrow going downwards indicates there is more osteoclast activity going on. But eventually, the arrow going up will become larger as the osteoblasts begin to pick up speed and fill in the pits. The osteoclast activity phase usually is done in 2 or 3 weeks, but it takes several months for the osteoblast to fill in that pit. So you can see that whereas the osteoclast works quickly to create a pit, it takes a long time for the osteoblast to repair that, and if vitamin D deficiency persists, then this can lead to weakening of bone and an increased risk for fracture. Actually, the condition that's created is osteomalacia in adults, or rickets in children, and that is a common cause of vitamin D deficient bone disease. The clinician can tell whether this process is going on by measuring markers of bone turnover, such as P1NP and CTX. And here's a more accurate drawing of what the cells look like in bone, and this is giving you some indication of what the bone remodeling cycle looks like and how this relates to markers of bone turnover. The bone remodeling cycle begins with the osteoclast, which is a large multinucleated cell, and this occurs over 10 days, certainly within a couple of weeks, 2 or 3 weeks, and then the osteoblast, which is shown on the right hand side, kicks in and starts to repair, and it takes several months for that repair to occur. But it starts with making osteoid. You can measure markers of bone turnover to see really what's going on. And in the middle there is the osteocyte, which is actually derived from the osteoblast. As it builds bone around it, it gets trapped in the bone, and you can see that the osteocyte had these long dendritic processes which interact with the osteoblast and the osteoclast. So the osteocyte is felt to have a major control over osteoclast function and osteoblast function, which we'll be getting into. Now, it's important to know about calcium homeostasis, and this is how the body maintains a normal serum level of calcium under various conditions. For example, vitamin D deficiency or perhaps there's a very low dietary intake of calcium. Your diet is very deficient in calcium, or there are increased needs for calcium. All the organs of the body need calcium to function properly. But it's very important to keep a normal range of serum calcium, which generally is in the range of 8.6 to 10.2 milligrams %. And when the serum calcium levels become low, the body needs to take calcium out of bone, because all cells need calcium delivered in serum in order to function properly. Now, let me qualify that. It doesn't necessarily have to take serum calcium out of bone. If you take a little extra vitamin D and calcium and you get better calcium absorption, there's no need for the body to take it out of bone. And if the dangers of taking it out of bone is that the pits are formed and the bones become more fragile and prone to fracture. So it's very important to keep in mind that in order to protect the bones from losing their calcium, keeping it in the bank, so to speak, to ensure adequate vitamin D and calcium. And here is a diagram which kind of represents the whole process of calcium homeostasis. It's not as bad as it looks. If you look on the left-hand side, it says, in the red rectangle, it says decrease of serum calcium. And the oval circles above and below are the causes of the decrease of serum calcium. On the top, you see there's severe dietary deficiency of calcium. That's one cause. And down below, if there's a reduction of active vitamin D, and by active I mean the 125 dihydroxyvitamin D, which is made in the kidney. But if there's active vitamin D from low sun exposure, or drug toxicity affecting vitamin D metabolism, or renal failure, where the 1 hydroxylation cannot occur normally, then this will lead to decreased intestinal absorption and or renal reabsorption of calcium, along with parathyroid hormone, which then leads to the decrease of serum calcium, and subsequently an increase of parathyroid hormone. You get a secondary hyperparathyroidism. Now, parathyroid hormone will stimulate the osteoblast to do two things. One, it will stimulate the osteoblast to make osteoid, which is the matrix for bone, and it also stimulates the formation of RANK ligand. And a ligand just refers to a molecular group that binds to another chemical entity, essentially a receptor. So the RANK ligand binds to the RANK receptor, and the RANK receptor is in the macrophage, and you see on the very top blue oval there the macrophage with the RANK receptor, and the RANK ligand, which is released from the osteoblast, actually goes on the cell surface of the osteoblast, will lead to conversion of circulating macrophages into osteoclasts. That's where the osteoclast comes from. It comes from macrophages in the bloodstream. So RANK ligand, produced by the osteoblast, stimulates the conversion of macrophages to osteoclasts. And you can see on the yellow rectangle there is talking about osteoclast formation and activation. Okay, and once the osteoclast is formed, then demineralization of bone will occur, and this will lead to an increase of serum CTX, which comes from the breakdown products of osteoclast activity. So it's very interesting that the osteoblast has a bone formation function, making osteoid, but it also has a bone resorption function through its RANK ligand effect. Now, once the bone becomes demineralized in those pits, the calcium is released into the serum, and it then feeds back through a feedback inhibitory loop to parathyroid hormone, which then that tends to decrease the parathyroid hormone. But if the vitamin D and calcium, for example, is not corrected, if you don't correct the serum calcium with supplemental calcium and vitamin D, then that feedback loop will not suppress the parathyroid hormone, and so that cycle will continue of increased PTH leading to RANK ligand, osteoclast formation and activation, and a release of calcium from bone, just to keep the serum calcium level up in the normal range. And so the way to stop that from happening is just give some vitamin D and calcium, and that'll calm it down, so you don't have to take the calcium out of bone. And here's just a little kind of a close-up of what's going on here, of how the osteoblast, which has on the top there, and this could be the osteoblast or the osteocyte. And I'm going to be talking about the osteocyte next, but just looking at the osteoblast, you see the RANK ligand on the cell surface there, and it's interacting with the RANK receptor on the macrophage in the blue cell in the middle there. Now, OPG is osteoprotegerin, is a RANK ligand inhibitor, and that acts just like Prolia, denosumab, that you can get from the physicians can order that to treat osteoporosis, and it'll block the RANK ligand from interacting with the RANK receptor on the macrophage, and the osteoclast will not form. So once the osteoclast is formed, then it starts making hydrochloric acid and collagenases. And I'm going to just show you a little bit of a close-up of the osteoclast slide. Now this slide is another drawing of the osteoclast, and it shows the Cathepsin K, which is an enzyme produced by the osteoclast, and it breaks down the type 1 collagen to make CTX, or the C-terminal telopeptide of type 1 collagen, as I mentioned before. And it also releases calcium into the bloodstream. Type 1 collagen is the collagen found in bone. And so we measure the breakdown products of type 1 collagen. And CTX is becoming the most reliable one. There are others, but I think this is becoming more popular and more standard to measure CTX. So I'll also mention that there are drugs being developed, and one reason why I'm going into this physiology is once you understand the physiology here, you can understand what the drugs that you're prescribing are doing. And the Odanacatib is an antibody to Cathepsin K, and this will probably be on the market within a couple of years as a drug treatment for osteoporosis. But what Odanacatib does is, it's an antibody against Cathepsin K, and it stops Cathepsin K from working. And of course, you can show that it's working because the CTX levels in the blood will come down, just like you're using a bisphosphonate. Bisphosphonates also inhibit the osteoclast through a different mechanism, and that's the topic of another talk, which is available if you're interested in how the bisphosphonates work. But this will be on the market, and there are other drugs that are being developed, which I'll get into later on. Okay, now let's talk about the osteocyte. We talked about the osteoblast, we talked about the osteoclast, now the osteocyte, which this is a slide from Dr. Nancy Lane, and she calls it the boss. And you can see the yellow stain there with the dendrites, the dendritic processes, and these dendritic processes interact with the osteoblast and the osteoclast, and we're going to get into how they control the osteoblast and the osteoclast. Okay, here's a drawing of the osteocyte from Matsuo, an article of Matsuo, and this shows the osteocytes with the long dendritic processes. There are 3 of them there, and you can see how they interact with the osteoclast, and in the red are on the left, and the osteoblast in the blue on the right. That the osteocyte, turns out, produces RANKL ligand, and it also produces sclerostin. Now, RANKL ligand will stimulate the formation of osteoclast. We talked about that before, by interacting with macrophages that have the RANK receptor. And I don't think I told you what that stands for. That RANK stands for receptor activator of nuclear factor kappa B, and then there's a ligand. So it's a receptor activator of nuclear factor kappa B. So the osteoclast is formed either from the osteocyte or the osteoblast thanks to RANK ligand. Now, sclerostin, very interestingly, inhibits the formation of osteoblasts. So it stops bone formation. So think about that. When you when you stimulate the osteocyte, when the osteocytes get stimulated, and we're going to talk about what stimulates the osteocyte in a minute, but when those osteocytes get activated, both RANK ligand and sclerostin are inhibited. It's a double whammy. Not only are you increasing bone breakdown by increasing osteoclast, you're inhibiting bone formation by stopping the osteoblast. You're stopping the osteoblast and stimulating the osteoclast. What could be worse? So, I mean, why does the body do this? So we're going to get into this now. Okay, this is the just a modification of the slide I showed you before. We'll go over to the osteoclast formation and activation, and this shows what causes activation and formation of osteoclast. Now, we talked about RANK ligand, but above and below that rectangle, this is new information. It shows that physical inactivity and loss of mechanical stress on bone is detected by osteocytes. So physical inactivity, being a couch potato, staying in bed, being bedridden, inactivity will stimulate activity of the osteoclast. And physical activity, all those exercises that we were talking about before, actually inhibit the osteocyte from functioning. So when you inhibit the osteocyte, the sclerostin levels go down and the RANK ligand levels go down. So now the other thing that will stimulate osteoclast formation is a decrease of serum estrogen. And this can happen in men and women. And estrogen normally inhibits osteoclast function. And so when you lose estrogen at menopause or andropause, depending on whether you're a man or a woman, you will see the CTX levels, start to go up because osteoclasts are becoming more active, taking calcium out of bone, demineralizing bone. And of course, the typical treatment for that is a bisphosphonate like Fosamax or Actonel or Boniva to inhibit the osteoclast, and this will allow less mineral to be lost from bone. It will reduce the demineralization of bone, and you will see the serum CTX levels go down after you start a bisphosphonate or a Cathepsin K inhibitor as well. So we're now going to be focusing on physical activity, the physiology of physical inactivity and activity. Okay, this is another slide showing what sclerostin does to the osteoblast, and you can see on the far right-hand side of the slide the pink mesenchymal cells, which are the precursors of osteoblast, lead to osteoblast formation through the Wnt pathway. Now, I'm not going to get into Wnt simply because I don't really know much about it, but it's the genetic pathway, and it stands for wingless something or other. It's a pathway that was discovered actually in fruit flies, but it's very important for cellular differentiation. You can look it up. You can look it up in Wikipedia or Google it if you're really into this to see exactly how these cells get differentiated. But it's pretty complicated stuff, and if you're just a clinician, you may not be terribly interested in that so much. But the point is that you can see that the osteocytes embedded in the yellow bone there, the blue circles are the osteocytes, that those osteocytes with the dendrites will, by releasing sclerostin, will prevent the osteoblast from forming, and therefore the osteoid in the pink there becomes less and less as time goes on. So on the far left, you can see where it says mechanical loading. If that is reduced, if you have reduced mechanical loading, this causes release of sclerostin. So if you become bedridden, if you lose physical activity, sclerostin will be released, and that will inhibit the formation of bone. But as we mentioned before, it will also stimulate the release of rank ligand, and that's not on this slide. It doesn't say anything about rank ligand, but we know now that the osteocyte, which, as you'll recall, comes from a further differentiation of the osteoblast, and once the rank ligand is released, then the osteoclast become formed from the macrophages. So mechanical unloading or loss of physical activity leads to activation of osteocytes, and this then leads to shrinkage of bone and increased bone fragility if it continues. And one more diagram here. There's a lot of information on this slide, but again, looking at the osteocytes, I'll take you through it. Looking at the osteocytes as they interact with the osteoclast and the osteoblast, there's stimulation of the osteoclast and there's inhibition of the osteoblast accomplished by the osteocytes. So with loss of physical activity, this leads to mechanical unloading, shown at the bottom of the slide there, and this leads to activation of the osteocytes, which then causes release of RANKL and sclerostin, and you have inhibition of bone formation and stimulation of bone resorption. So you'll see P1NP levels go down and CTX levels go up with mechanical unloading. We're staying on the couch too much. And I've also put on that slide what's going on in the serum with parathyroid hormone activating osteoblast. It's a different system, a different way that osteoclasts can form through the action of parathyroid hormone. But it seems like sclerostin, it's not quite clear the interaction between parathyroid hormone and sclerostin, but there's new information coming in all the time about this. Now the other question is the role of osteoprotegerin and the vitamin D receptor in the osteocyte nucleus, that the 125-dihydroxy vitamin D interacts with the vitamin D receptor in the nucleus. We know now that vitamin D does a lot more than what we learned in medical school, and that this may control the amount of rank ligand that's produced. In other words, you may not get a lot of bone breakdown from this process when the osteocytes get stimulated. If the osteoprotegerin and vitamin D are playing a role here, it may inhibit the ability of the osteocyte to cause bone breakdown. It may just work on the bone formation. It depends upon what the serum calcium level is. So this is really getting complicated, but this is important information to know, because the drugs that are being developed are based on the physiology that we're talking about. And let's get to some clinical examples here. This is a study by Ardawi. It was in the Journal of Clinical Endocrinology and Metabolism about a year ago. And just looking at the bottom panel there, you can see this is This is a group of women who underwent a physical exercise program. It's a physical activity training, and I think 4 days a week, they went through a rather intensive program of physical training. And there were 30 minutes, and then 30 to 60 minutes, and 1 to 2 hours, and then greater than 2 hours. And they showed that the sclerostin levels, when they did as much as 2 hours, 4 days a week, this led to suppression of sclerostin levels and an increase in insulin-like growth factor 1. Now, this is just another measure of bone formation. They also looked at the other markers, which I'm going to show you on the next slide. Okay, now this is a lot of information here, but if you'll look at the sclerostin under the physical activity training. The PAT stands for physical activity training. There were 58 women in this group that underwent the physical activity training, up to 2 hours a day. And this went on for 8 weeks, and they measured sclerostin levels before the training and then after the training. And you can see the sclerostin, you see the star there next to the sclerostin, the serum sclerostin level went from 26 to 19. And that was a significant suppression to have actually an age-matched control group, and shows that the baseline of 25.69 was 26.41 at the same time. And so this showed suppression of sclerostin, and then also starred the serum P1NP and the CTX. The P1NP went up from 23.5 to 29.4, and that was a significant increase, and the serum CTX went down, just as you expect from physical activity. So this is an actual example of the physiology showing that when you do a lot of weight-bearing physical activity, you'll suppress your sclerostin, and this will lead to increased bone formation as reflected by a rise in serum P1NP and a suppression of bone breakdown, which is reflected in the reduction of the CTX. So again, this is a real-life example of the physiology. And there are a number of studies which show this, that bed rest, for example, cause the sclerostin to go up. But there's actually a fair amount of literature, and there's a lot of stuff coming in. So I would imagine that over the next few years, if you have a patient that you would like to have an exercise program for, and you wanted to show that this exercise program was enough to really affect their bone metabolism, you could actually get a baseline sclerostin, P1NP, and CTX, and then put them on the program, and then a few months later recheck them and see if the sclerostin is suppressed. And if so, you would expect the bone mineral density to eventually increase, so you can monitor the effect of your exercise program. Now, this is probably not going to be done too much as it is now, but I can see that this is something that in the near future doctors may start doing. The doctors that are very interested in using physical exercise as a treatment to improve bone health. Okay, so what can we conclude? Weight-bearing physical activity can improve bone strength by suppressing osteocyte activity. Physical exercise-induced suppression of osteocytic activity leads to reduced sclerostin production, which promotes bone formation and also reduces RANK ligand production, which reduces osteoclast formation and activity. Lack of exercise may cause increased secretion of sclerostin. Actually, there's a lot of support for that. Clinically, one would see a rise of serum P1NP and a reduction of serum CTX with meaningful exercise. Muscle strengthening and non-impact exercise can also provide benefits that lower the risk for fracture. If exercise is not enough, there are new drugs now, and there are drugs that are being developed for osteoporosis, and you know about teriparatide or Forteo. That's available. Denosumab or Prolia is an inhibitor of RANK ligand. That is available. There's calcitol, which is an analog of 1,25-dihydroxyvitamin D, which apparently has been demonstrated to improve bone density much more effectively than regular vitamin D3 or vitamin D2. There's Odanacatib, which I mentioned before, an antibody to Cathepsin K. And then there are anti-sclerostin antibodies, which are being developed, one by Eli Lilly, Blasozumab, and Ramazumab by Amgen. If I'm pronouncing those correctly, I'm not sure. But there are others that are undergoing development. So this area is exploding. There's so many new developments, insights, and treatments being developed to improve bone health. So be sure to stay tuned for more information. Okay, that's pretty much it, and thank you for listening. If you have any questions, send me an email to ifcd.pmay@gmail.com, and please visit our website at www.chronicdisabilities.org. Thanks again. Bye-bye.